Good afternoon again. That's Walid Tawfiq on another case scenario for FRCS exam. We have a 42 years old man who had severe bilateral hip pain, worse on the left hand side. What do you see and how we are going to manage this case? So this is the clinical photograph and the plane radiograph EB of the pelvis, showing about in the clinical photographs use a bilateral flexion attitude of the hips and knees. Patient standing with a stooping gait. So I suspect he had a lumbopelvic pathology. On the plane radiographs showing a bilateral symmetrical hip arthritis with uniform joint space narrowing and protusion on the left hand side. So I suspect this, and there is a sacroiliac joint uh, ankylosis with ankylosis of the lower lumbar spine in the profile picture. I suspect the gentleman had some sort of inflammatory arthropathy. The commonest with this presentation is the um, is ankylosing spondylitis. So I will have a detailed history from the patient by assessment, ensuring the hip is originating from the pain is originating from the hip joint. History of red flags that suggest a serious pathology. I will do an Oxford hip score. What's the treatment so far the patient had? What his limitations and expectation? Ask about past hip history and other joint history, especially if there is an skeletal or exoskeletal manifestation of ankylosing spondylitis, and if there is any biological treatment for that. I will do my examination general looking for extraskeletal and ankylosing spondylitis feature. Local, I will stand the patient looking for overall alignment, his gait, abductor function. I will check for Thomas test for fixed flexion deformity, his hip range of movement, check for limb length discrepancy, neovascular examination, and the full spine examination in the knee. I will do investigation in the form of imaging. I will get plain radiograph, other views, including the whole femur, to check for deformity. I will get the X-ray for the whole spine, looking for spine deformities. I will do CT scan of the pelvis, looking for and the hips, looking on the femoral side for any deformities, and the plan accordingly. And on the acetabular side, looking for the socket site size, bony defects, and the planning for component site and size. I will do blood tests, including full blood count, use and ease. I will cross match for if I think about embarking on surgical option. My treatment aim is to get a pain-free, mobile, stable hip with restoration of center of rotation and offset and limb length equality. The guidance about that is a nice guidelines about joint replacement for hip arthritis. The principles of that is that should be in a multidisciplinary approach setting, as this is an example of complex primary hip replacement. Assuming the patient had exhausted all non-operative treatment and he is symptomatic enough and fit enough to go ahead for surgery, I will do a hybrid hip replacement with dual mobility bearing surface to decrease the risk for dislocation. And the specific challenges for this condition, there is a pre-operative, intraoperative, and post-operative. Pre-operative should patient should have an aesthetic review as he had a stiff spine with difficulty intubation and temporomandibular joint stiffness. He had a limited chest expansion and closed lumbar spine, which makes spinal anesthesia quite difficult. I will do a cardiac. I will ask for a cardiac review for him, as this patient commonly have a cardiac valvular disease. I will involve a senior hip surgeon to get it right first time. Those patients with ankle bone have a higher risk for revision, giving the altered spinopelvic mechanics. This patient is a young patient who had a higher risk for to wear out his hip and use a higher risk for infection. Other specialties need a rheumatology review for optimization of medication pre-operative, and if he's on any biological medication, the rule of thumb is that needs to be stopped prior to surgery. I will involve a spine surgeon as well in the discussion to look for what is the next step, either to start with his spine or hips in a multidisciplinary approach team. Intraoperative, as we got the exposure, I will go through posterior approach. As we can see, the hip is quite the acetabulum is quite protrusive, so I have to be careful about this exposure and the protection of the sciatic nerve. I will do a femoral neck section in situ to facilitate the head extraction, as dislocation may be difficult. And the acetabular side, I will ream the socket with the bigger reamer and to start with. On the opposite, we do usually with the smaller reamer, and I will avoid medialization of the cup. I will use the femoral head as a graft to restore the center of rotation of the hip joint. On the femoral side, always think about I would think about is a bone quality and avoid any vigorous maneuver to avoid break or intraoperative fracture. And I will look for any deformity and deal according to that. Post-operative routine, post-operative rehabilitation, thromboprophylaxis, and heterotopic ossification prophylaxis, as this patient has a higher risk for that.